Good afternoon from here in Bahrain. And I'm sure there are people joining from different parts of the world from different time zones. So good evening and good morning to others. So I'm going to speak on an important medical subject that is not very well recognized, but once you recognize and you manage it, then this can be not only a life-changing experience, but it can also be a life-saving experience. So in the next 30 minutes or so, what I'm going to do is to mainly give you an overview as to what sleep apnea is. But I'm not going to dwell much on this, but because my main core of my talk will be as to how sleep apnea impacts cardiovascular system. So this is where I'm going to spend more time. And then finally, I'm just going to discuss very briefly about the management strategies as to how we can manage sleep apnea to alleviate the complications, the cardiovascular complications. So starting with as to what is sleep apnea. So sleep apnea is a condition in which a person will have multiple episodes of short or extended pauses in breath. So when a person is sleeping, he or she will stop breathing for a few seconds, anything between 3 to 5 seconds, even 10 seconds, up to 30 seconds. And this temporary cessation of breathing or breathing lapses causes poor quality of sleep, but that's not a big deal. But because of the deficiency of oxygen, it does lead to potentially various serious health consequences. Sleep apnea, the prevalence, the global prevalence is 1 billion or more individuals are affected by sleep apnea. In the United States alone, the prevalence of sleep apnea is 18 million. But the sad part is that you can see on the slide here, 10 million, more than half of the patients or people who have sleep apnea are never diagnosed. Sleep apnea is common in men. It involves 1 in 4 men and 1 in 10 women. And people who are smokers, the prevalence or incidence of sleep apnea is much higher. Sleep apnea significantly increases the risk of heart attack, and it also increases the risk of diabetes and other metabolic conditions. Now, there are mainly 3 types of sleep apnea, but the commonest one is the obstructive sleep apnea. And as you can see here in the picture, that there is obstruction due to the soft tissue behind your throat, which involves your pharynx, your tongue. They get loose while you sleep. And while they get loose and more loose than normal, it is going to obstruct the airway or the passage where the air or oxygen flows to your trachea and then to your lungs and to the rest of the system of the body. So this kind of sleep apnea is the prevalence is almost 80%. So this is the commonest type. Now then there is a second type of sleep apnea, which is called the central sleep apnea, in which the passage is open for the air or oxygen to flow very nicely here, as you can see. But the problem is in the center of breathing. The center of breathing, if you ask where is the center of breathing, it is in the brainstem, particularly in medulla. So that is the center that controls your breathing. So that center does not get enough stimulus to trigger or give the reflex forward to help the muscles of breathing to act in a way that the person can breathe. So in this situation as well, the person stops to breathe and then takes few rapid breaths. So there is rapid breathing, then stops to breathe for a few seconds. So this chain continues. And this is sometimes also called the Cheyne-Stokes breathing. And then the third variety, which is the least commonest, is a combination of both, where the person can have obstructive sleep apnea as well as central sleep apnea. And this is called the complex sleep apnea. Now, sleep apnea involves almost every system of the body, you name it. But my job today is mainly to focus on the cardiovascular aspect as to how sleep apnea leads to cardiovascular complications. Now, the cardiovascular complications or problems are listed here, and these complications can be anything simple as hypertension to something very serious like sudden cardiac death. In between, you see the complications like cardiac arrhythmia, coronary artery disease or heart attack, myocardial infarction, stroke, pulmonary artery hypertension, and heart failure. The pathophysiology as to how sleep apnea leads to cardiovascular complications is complex, but it is down to mainly three. One is hypoxia, second is negative intrathoracic pressure, and third is arousal that increases the sympathetic activity of the body. Now, as you can see here on this chart, the pathophysiology is explained in a little bit more detail. Now, once there is sleep apnea, and more commonly, as I mentioned, is the obstructive sleep apnea that leads to decrease in the oxygen supply to the body. And in addition, there may also be a decrease in the carbon dioxide or increase in the carbon dioxide. When such a situation arises, it causes a systemic inflammation. There is hypoxia, and hypoxia leads to oxidative stress. And in addition, there is endothelial dysfunction. There's also sometimes vasoconstriction. So putting everything together, this is going to have effect on the heart. It can going to have effect on your arteries, to your heart, to the brain, and your peripheral circulation. In addition, as I said, that the person does not have a very good sleep during sleep apnea, he or she subconsciously will wake up a number of times, and this is called arousal. When this happens, then there's a lot of neurohormones that are high, a lot of catecholamines. These are the stress hormones, norepinephrine, epinephrine. They go high up in the bloodstream. In addition, there's a hormone called stress, another stress hormone, which is cortisol that increases in your blood as well. In addition, there's decrease in the intrathoracic pressure that leads to increase in the preload to the heart and also the increase in the afterload to the heart. So this is in a nutshell the pathophysiology. Now, the cardiac complication that it causes, the most common complication is hypertension. So if somebody has got sleep apnea, then it is very much likely that it can raise your blood pressure by a few and sometimes many millimeters. And it is estimated from studies that nearly half of the patients who suffer from sleep apnea have got high blood pressure. Now, this blood pressure may not be diagnosed unless you particularly look for it and you measure the blood pressure for that person. And by and large, you'll see that this patient's blood pressure may be high. Now, the problem does not end here. These are the patients who will have blood pressure, what we call resistant hypertension, where this kind of blood pressure will not be easily treatable. Like we give for some patients blood pressure tablet, one medication, maybe we add two medication, but in this, they may require 3, even 4 medication to control the blood pressure. So it is very, very difficult to control the blood pressure if they are related to sleep apnea. In addition, if I put a monitor, which is called the 24-hour blood pressure monitoring device on this patient that records the blood pressure 24 hours during the day as well as during the night when the patient is sleeping. Now, the normal physiology, as you all know, that when we sleep, we tend to relax, we tend to retire, and that will essentially lower your blood pressure. In sleep apnea, because there's arousal, the person subconsciously wakes up a number of times. The blood pressure, instead of getting better or lower than the day blood pressure, it in fact rises, and this is called nocturnal hypertension. In addition, we also see a phenomenon called dipping. So when the person sleeps, the blood pressure should go down at certain hours when the person is in his or her deep sleep. And this is called dipping. And if this blood pressure does not go down, does not dip, these patients are classified as non-dippers. And if they are non-dippers, then these patients are an independent risk for having future cardiovascular complications and cardiovascular mortality. Now, presence of hypertension, which may be related to the sleep apnea, in addition to the other comorbidities, like these patients are mainly obese patients. These patients are likely to have high blood pressure, have diabetes, high cholesterol. They all will collectively increase the risk of cardiovascular event like heart attack and stroke, and also cardiovascular mortality. Now, coming to arrhythmia. Now, one thing we know that there is no exact prevalence about arrhythmia that is related to sleep apnea. And in addition, we also do not know the pathophysiology very clearly as to how arrhythmia occurs in presence of sleep apnea. But the commonest or the common types of arrhythmia that are seen in patients who have got sleep apnea are bradyarrhythmias, where the heart rate becomes slow. The heart beats less than 60 beats per minute. There are other types of bradyarrhythmia like sinus pause, there's no electrical signal, or there is first degree AV block, or the second degree AV block, which is morbid staph 1. Rarely, there may be some tachyarrhythmias where the heart beats fast. The commonest are these extra heartbeats that come from the lower chamber of the heart. Sometimes the heart will go very, very fast. This is called supraventricular tachycardia. Sometimes the heart will go into irregular rhythm. This is called atrial fibrillation. And the risk of atrial fibrillation increases by 5-fold. There can also be a very abnormal rhythm called ventricular tachycardia. This can be sustained or non-sustained. So pathophysiology again is very similar. So there is intrathoracic pressure lowering, there's arousal, and there's hypoxemia. Then putting this together for a prolonged period of time, when I say prolonged period of time, it could be days, weeks, even months and years together, they cause structural damage to the heart muscle, to the arteries, and in addition also causes damage and change to the electrical pathway in the heart. When the electrical pathways they are disturbed, then they are triggered and can lead to an abnormal heart rhythm, which we call cardiac arrhythmias. So what is the management of arrhythmia and sleep apnea? Now, the clear-cut answer, there is no definite management. What you're going to concentrate on is to able or try to reverse the sleep apnea. And how you can reverse sleep apnea, the best way is lifestyle change. And lifestyle change mainly involves weight loss. And we are not talking about weight loss of 1 or 2 kilograms. The weight loss should be a significant weight loss, even 10, 15, 20, or even more. In addition, the person may be tried on what is called CPAP. Now, CPAP is continuous positive airway pressure. I'll talk about it in my future slides. This is essentially giving oxygen under pressure, and that helps to increase the oxygen supply for the patient or that person. The antiarrhythmic drugs are generally not indicated for these patients, and specific targeted therapy is only indicated if there are some electrical conduction abnormalities that are diagnosed. Now, in the past, people have tried atrial overdrive pacing as a means of controlling this arrhythmia, but this does not help, and therefore this is not recommended as one of the treatment guidelines. Now, coming to as to how sleep apnea increases the risk of coronary artery disease and also increases the risk of stroke. Now, we know through studies that if somebody has got sleep apnea, then the risk of coronary artery disease increases by 30%, and the risk of stroke increases by 60%. Yes, 30% increased risk of coronary artery disease and 60% increased risk of stroke. It does not stop there. These cardiac events or cardiovascular events, they happen prematurely, which means they will happen at a young age, even if the patient are in their 40s or 50s. And when there is presence of sleep apnea and they cause heart attack or stroke, then the cardiovascular mortality increases as well. That means these patients are at risk of dying prematurely or quite early onset of death they may have. Pathophysiology again is very similar. As I explained earlier, there's hypoxia, there's oxidative stress, there's systemic inflammation, and that leads to endothelial dysfunction. But in addition, as you see here, there is metabolic dysregulation. And when there is insulin resistance, the patients may be diabetic, new onset of diabetes. They'll have abnormal lipid profile, high LDL, and so on. In addition, there is sympathetic excitation due to frequent arousal, and that will lead to increase in the heart rate as well as increase in the blood pressure. And both are detrimental and can aggravate the atherogenic plaque to develop and then to rupture and cause a full-blown myocardial infarction and also lead to stroke. So once there is a obstructive sleep apnea, coronary artery disease, and stroke, so there are other comorbidities that coexist. Obesity is one of them, diabetes and hypertension, as I said, they all go hand in hand. Patients may develop atrial fibrillation due to sleep apnea, and this is again going to predispose to ischemic stroke. Studies have shown that patients who have got sleep apnea are at risk of developing subarachnoid hemorrhage, and this subarachnoid hemorrhage develops at an early age. They predispose to fatal and non-fatal myocardial infarction. It has also been seen that these patients undergo revascularization. There's higher incidence of revascularization. When I say revascularization, it essentially means angioplasty or PCI and coronary artery bypass surgery. And as I mentioned earlier, that these patients also have got higher cardiovascular mortality. It is also seen through studies that the severity of obstructive sleep apnea directly correlates with the cardiovascular complications and the mortality. So more severe the obstructive sleep apnea, which is measured by a sleep study, and there's something called AHI score, which I'll discuss. And higher the AHI score, higher is the risk of cardiovascular complications and higher is the risk of cardiovascular mortality. Presence of obstructive sleep apnea. If somebody has got obstructive sleep apnea and if such a person is going for surgery, particularly non-cardiac surgery, such a person is very likely to get more cardiovascular complications and they're at risk of also dying during the surgery. And obstructive sleep apnea and its severity should be included as a risk marker of future cardiovascular events. Now, some of you may know that we have got a way of risk stratifying people who may have a future risk for developing heart attack and stroke. Some of the common ones, there's a Framingham score, there's a Q risk 3, and there are a few others. So we have few numbers. We take into account few parameters like age of the person, then the other traditional risk factors, diabetes, blood pressure, smoking, and so on. We put them together and we come with a percentage. And then we say that this is the risk of developing future heart attack or stroke in next 10 years or so. But obstructive sleep apnea is not one of the factors taken yet. But I believe this should be included as one of the parameters that should be taken into account. Now, coming to heart failure. The heart failure is a hot topic nowadays. And everywhere, if you go to cardiology meeting, you will not come back without listening a lecture on heart failure. Now, sleep apnea has been recognized as a part and parcel of heart failure, and they are quite interrelated. And when I say interrelated, when somebody has got sleep apnea, then it increases the risk of increasing the risk of developing heart failure. If somebody has got heart failure, there's always a risk of developing sleep apnea, and particularly the central sleep apnea. And it is known that 50% of the patients who have got heart failure also have got obstructive and more commonly central sleep apnea. And sleep apnea increases the risk of heart failure by 140%. So 140% the risk increases of heart failure if somebody has got underlying sleep apnea. But once again, the exact prevalence, the exact pathophysiology in heart failure as to how heart failure develops in sleep apnea is not very well known, but there are some mechanisms that are postulated, which I'm just going to discuss. Now, we know for sure that there are some preponderance for heart failure in sleep apnea patients. And some of them mentioned here are patients who are above the age of 60, who are male, and who have got heart failure, class 3 and class 4, these are advanced heart failure. So they are likely to develop central sleep apnea. But for some unknown reason, sleep apnea is not commonly seen in female patients of heart failure. We don't know the reason, but this is something that has been observed, that female heart failure patients, they have not been very commonly seen to have central sleep apnea. Now, what are the factors that influence heart failure and sleep apnea? Comorbidities like hypertension, atrial fibrillation, sympathetic overdrive, more of catecholamines like high epinephrine and norepinephrine in your bloodstream, increase in the preload due to a decrease in intrathoracic pressure, and also once there is increase in the afterload, this is going to raise the left ventricular end diastolic pressure, and obviously this is going to lead to impairment of left ventricular systolic function, and there the left ventricle does not pump well enough, and eventually it will fail completely or proportionately, and then this will lead to all other symptoms and signs of left ventricular failure. In addition, there are mechanisms and pathophysiology in a way that there's a rise in the pulmonary artery pressure, and because this is the right heart pressure, and once the right heart pressure increases due to rise in the pulmonary artery pressure, this is going to predispose to right heart failure. So the patient is at risk of developing left heart failure, as well as there's a risk of developing right heart failure. Heart failure and sleep apnea, as I said in the beginning, they coexist. And central sleep apnea, if somebody has got central sleep apnea in heart failure, then this alone is an independent risk marker of mortality. So central sleep apnea should be observed very carefully in heart failure patient, particularly when he or she is sleeping or they're retiring to bed. So please observe for the central apnea, because if you observe central sleep apnea, then you can say that this is a person or a patient is at risk of higher mortality, and you have got to take action and treat that central sleep apnea in order to prevent another death from heart failure that may be related to sleep apnea. And presence of heart failure and sleep apnea together worsens the mortality. If somebody has got only sleep apnea and only heart failure, then the mortality is not much higher. But once they are put together, then the mortality is going to be much, much worse. Now, this graph shows that if somebody has got AHI index is apnea index. This is a way of measuring the severity of sleep apnea. If the AHI index is lower, as shown in the blue curve, then this has got a better survival. If the AHI index is higher, and if it is more than 5, it says here, but again, 5 is nothing. The severe form of sleep apnea is where AHI index is more than 30. And between 15 and 30 is moderate, and less than 15, it's mild. But this paper, remind you, is from 2007. It's quite an old paper, so things have changed a little bit. So anyway, it very clearly shows that if the AHI index is more, then it is more severe form of sleep apnea, and here the survival is much lower compared to less severe sleep apnea. Now, sudden cardiac death, as I mentioned, is the most worst form of cardiovascular outcome that you can expect in sleep apnea. And it has been seen that obstructive sleep apnea raises the risk of sudden cardiac death by 300 to 400%, depending on the severity of OSA. Obviously, these are the patients with severe form of obstructive sleep apnea where the AHI score will be more than 30, and they are at risk of sudden cardiac death. And this sudden cardiac death may happen during sleep, and patient may not be aware of. And there may be other causes that may be blamed for, or somebody, he may have had a heart attack during sleep, he may have had a stroke and something, but it will all may be entirely due to sleep apnea that may trigger a malignant arrhythmia like ventricular fibrillation or non-ventricular tachycardia, and that can lead to the death of the person, and that can happen suddenly without any warning. But published reports we have so far that raise the association between the obstructive sleep apnea and sudden cardiac death. There is an association, but obviously we do not know the exact mechanism how it causes. As I mentioned earlier, the severe the sleep apnea, more worse is your survival, your probability of survival. and less the AHI score, less than 5, as I said, is the mild, up to 15 is mild, and here the survival is better. Milder sleep apnea, better survival. Worse the AHI, more the AHI, more than 30, then poor is the survival. Now, quickly, I'm just going to go through management strategies. Now, weight loss is the key to managing obstructive sleep apnea, because majority of these patients, they are obese, they have got a very high BMI, even up to 40 and more than 35. So they're very, very obese patients. While they're obese, they have got a lot of tissue here in the neck and the back of the throat. They become very loose, and they can obstruct the airway when they go to sleep. So weight loss is the key management. And once you start the management, when you discuss the management strategy, do not forget the weight loss, because this is the key to manage these patients. And this weight loss, not 1 or 2 kilos, not 5 kilos. We are talking about weight loss of 10 kilos, 15 kilos, 20, 25 kilos. That much amount of weight they need to lose to see the benefit. But obviously, any amount of weight loss is going to be beneficial. In addition, CPAP, as I said, is a machine I'm going to discuss in my next slide. What CPAP is providing pressure oxygen through a device called CPAP machine. And in addition, there's another device called ASV, which is adaptive seroventilation. And this is mainly used for patients who have got central sleep apnea, where there's no obstruction. It is just the brain that does not trigger the ventilatory drive or breathing drive. And this works in a way that when you need to use it, then it will trigger off, will give you oxygen under pressure. When you do not need, then it will just remain quiet and does not do the work. It's just like what we call the demand pacing. But this was studied in one of the trials called SERVE heart failure trial. And this has shown that did not improve or increase the survival using this device. There are a few drugs called stimulants like theophylline, acetazolamide, and amphetamine. They have been tried mainly for central sleep apnea, but again, they are not very effective. Now, a couple of slides on CPAP and what are the cardiovascular benefits. So as I was explaining what is CPAP, this is a machine that you can see here. This is a mask. This is on the mouth as well as the nose. There are masks which can be attached only on the nose. They are much smaller and they are very tightly fitted so that they supply with the help of this tube, and they goes into a device here, CPAP machine, and that provides oxygen under pressure. And this pressure opens the closed airway and can give oxygen, enough oxygen to your lungs and to the rest of the body, and help you sleep better. You wake up better, you have better mood, you're more fresh, you're more energetic, and certainly it would help to reduce a lot of cardiovascular complications as well as the complication related to other systems of the body. What it essentially does, it increases the intrathoracic pressure, therefore leading to decrease in the preload to the heart, and it also decreases the afterload to the heart. So decreasing the preload and afterload, obviously it's a good thing for the heart, not only for heart failure, but also to reducing the incidence of arrhythmia. So what are the CPAP benefits? So CPAP benefits are essentially reversing everything that sleep apnea does. It improves oxygenation, reduces oxidative stress, improves endothelial function, it decreases the preload and afterload, and also reduces the sympathetic overdrive. And obviously, it has been shown through not one, but several studies, if CPAP is used, it helps to reduce the blood pressure by several millimeters of mercury, and you may also reduce the medication, and sometimes you may also be able to reduce or stop the blood pressure tablets, and you may not need any antiarrhythmic medication to treat arrhythmias. Now, in just a couple of slides, I'm just going to talk about the evidence. What is the evidence of using sleep apnea, and how does it improve the cardiovascular outcome? Now, this slide actually shows it is a meta-analysis of few observational studies on the top. So these are the observational studies, and these are the randomized controlled trials that have been done in patients with sleep apnea using CPAP sleep app machine. Now, this, as you may know, this is a line. Anything to the left, they are good, and that favors CPAP. Anything on the right favors control, where there is no CPAP is being used. So as you can see, is mostly the studies, what the results they got are onto the left, means if they have if the patients use CPAP, then obviously there is going to be benefit. But in addition to this, if you look at here, what I have just circled it, these are the p-values. P-values give you the, if they are statistically significant difference, then obviously they are not highly statistically significant, meaning thereby when you use CPAP, then there is benefit, but there is not a great deal of benefit in reducing the cardiovascular event. And this comes from the observational studies as well as the randomized controlled trials. Now I'm just going to discuss one trial in a little bit more detail. This is the SAVE trial, and this is the sleep apnea cardiovascular endpoint study, SAVE trial. This is studies from Australia, but it included patients mainly from China. More than half of the patients were from China, and then there were patients from Australia, of course, from New Zealand, from India, from Spain, and Brazil. But you'll be surprised, or you may laugh or smile, that only 4 patients were included from USA. Now, these included patients who had moderate to severe obstructive sleep apnea, not central, but obstructive sleep apnea. In addition, these patients were high cardiovascular risk, meaning thereby they already had heart attack, they already had undergone PCI or angioplasty, they had undergone coronary artery bypass surgery, or they had stroke, or they had transient ischemic attacks. So what they did, they randomized 2,500 patients into 2 arms. One arm to receive the usual care alone, means just weight loss and giving some therapies. But the other arm, in addition to the usual care, they also received CPAP. So they were given the machine, the CPAP machine, and they were followed up for a few years with this 1, 3, 6 months follow-up and 6-monthly follow-up thereafter. So what are the results that you can see here? And on the red line is usual care. That is the curve for the usual care. And on the blue is for patients who had CPAP in addition to the usual care. Now, what you will notice is that, yes, there's some benefit as you go along from 12 months to 2 years and 3 years and 4 years. You see the benefit up to say 60 months or so. And then again, the curves they meet at the end. And in addition, if I draw your attention to the hazard ratio, and if I draw your attention to the p-values, now the p-values, you will all agree, is not statistically significant. So the conclusion drawn from this study is, from the SAVE study, is that using CPAP, unfortunately, did not reduce the cardiovascular mortality. Now, this is something we do not understand why, but this is the sad part, that we know that what is the mechanism that the sleep apnea increases the cardiovascular mortality. And we also know that the CPAP machine is effective in improving the symptoms of sleep apnea. But unfortunately, when it comes to cardiovascular mortality reduction, this was not reduced. Now, we do not know the reason why this is, but there are some postulations that this study included patients who were not at high risk of sleeping, or they were not sleepy patients. They had lower AHI index or apnea hypoapnea index. They were less than 15. It is also postulated that perhaps these patients who were included did not adhere or did not comply with the use of the CPAP machines. So these are the few speculations that may have led to this difference. But there are few studies in the pipeline. Hopefully in a couple of years' time, we may see some different result. But definitely CPAP machine does lead to a significant improvement in lifestyle. Significant, I've seen in my practice, it is a game changer, to be honest. Once you give a CPAP machine to a person who has been living a life in misery for years together with sleep apnea, and once they get this CPAP machine, within a week, within 2 weeks, they're completely different. Now, to summarize, ladies and gentlemen, as I've alluded to you, that sleep apnea is common, but sadly enough, it goes undiagnosed in majority of the cases. And as I mentioned, that almost 50% of the cases, they go underdiagnosed or they are never diagnosed. Sleep apnea does lead to significant cardiovascular complications, and it also leads to adverse cardiovascular events. Once you suspect, the diagnosis of sleep apnea is not difficult. mainly the diagnosis is clinical. So you've got to have that suspicious eye. If you see a patient of sleep apnea, you may not even need to confirm the diagnosis. The diagnosis is mainly clinical, but obviously you need to have those numbers to assign so that you know the severity of the sleep apnea, and then you can risk stratify these patients. And finally, applying the right management strategies can not only lead to life-changing, but it can also lead to life-saving experience. So with that, I thank you very much for your patient listening, and I hope the talk or presentation was clear. But if there are any questions from the floor, I'm quite happy to take. Thank you.